Okay, guys, we're going to move on to one of the last chapters of the book, Geriatric Emergencies. So this is the older population. As you can imagine, a lot of the calls we get are from the geriatric population. So we got to know some of the facts and figures within this age group to really be good EMTs. So what we're calling that is basically anyone who's over the age of 65. Now, how fast one ages is a function of genetics, lifestyle, and attitude. And that's the weird thing about aging. Some people just seem to age faster, maybe because they're drinking and smoking all the time, or they're in the sun a lot. But you also have, like the Rolling Stones, who are in their 90s and they're still having kids and stuff. So it's quite the range for geriatrics, and we just need to be able to be flexible with the different patient presentations. Speaking of that, not everyone who's older has dementia. Not all of them are hard of hearing, and not all of them are sedentary or immobile. And actually, part of that is like location based. Like in certain states, a 65-year-old would never get a knee surgery, but in places like Idaho and Montana, they do because people are still active in their 70s. So some of those are even like location differences. Okay, so identify yourself, avoid showing frustration and impatience, which can happen with some of these older populations sometimes. Look at eye level, speak slowly and distinctly, and basically overall just treat them like a patient, which I know sounds weird, but especially people who've been in EMS for a while, just another old person. So try not to do that. So these are some of the things that could happen. Hip fractures are common. Their osteoporosis, their bones just aren't as strong, their bone density is weaker, and all their sedentary behavior can lead to pneumonia and some blood clots and things. So there you go. You can pause that if you want. It's just some of the things we're going to be seeing. All right, now it's going to be rough sometimes because of communication issues, hearing and vision deficits, alterations in consciousness. They might be a little out of it, especially if they're on a bunch of their prescription drugs. Complicated medical histories, yes, that you will definitely see that. And like I said, effects of medications, either side effects or medications interacting together. Okay, nature of injury may be difficult to determine, especially if they have dementia. Complaints may be vague. Chest pain, shortness of breath, altered level of consciousness should always be considered serious. Some of their pain responses aren't as strong, so they actually may be in a lot of pain, but they won't really feel it. So for the airway and breathing assessment for older people, just understand that they've lost some of those mechanisms. So they could have some airway issues, trying to get, like, for example, pneumonia, stuff like that, getting some of that mucus out. They're not able to do that as well. Poor perfusion, they're just not going to have as good perfusion as like an adult, as a normal adult. It can negatively affect that circulation. So basically, any complaints that compromises ABCs, got to go to the hospital. Any conditions are life-threatening, treat them to the best of your ability, but then really some of this stuff is going to have to handled in hospital. So another kind of guidelines for when we want to consider our patient's priority is when they're just a poor general impression, any sort of airway breathing issues, altered level of consciousness, and that's never good. Shock, severe pain, uncontrolled bleeding, the same as an adult. So this is just kind of general guidelines, just some things to do, kind of keep in your mind when you're interacting with geriatric patients. All right, the GEMS diamond, I love this thing. So you might see this on the test, right? So just be familiar with the different components, okay? So geriatric patients, or geriatric patient. So the environmental assessment, which is just going to be looking around at where they're living and kind of looking for some clues there. Medical assessment, got to make sure we do a really thorough medical history. And then social assessment. Yes, older people don't have as good of a social network, and that can negatively impact them. They may need assistance with activities of daily living, and that's just things like showering and cooking food, things like that. And that's an idea. You can get some information pamphlets and hand it out to your patients after you leave. Okay, so there you go. So GEMS model, just another graphic. So geriatric patients, they present atypically. They can be different than what you'd think. They deserve respect, of course, and that those things change with age. There's their environmental assessment. So that's looking at things like, do you have ramps? Do you have stairs? Like what's going on? Medical assessment, just keep some things in mind for that. And then that social assessment. So just know those four components. Okay. Yes. I heard that your body starts to degrade by 1% every year after 30, give or take. Well, think about that. 60 years old, they're down to a third. They're down 1/3 of their normal functionality. So um, your body does start to degrade as you get older. There we go. So we kind of talked about some of those changes. The airway musculature is going to be weakened. The alveoli just don't work as well, and the chemoreceptors are slow. So the body doesn't adjust as quick. Pneumonia, this is a pretty common thing for older people, leading cause of death from infection, and for geriatric populations. They get it a lot easier. And because some of these people, this is what they are. They're institutionalized. They're in a long-term care facility or something. They already have chronic diseases. They have a weakened immune system. They have COPD or cancer, and then the history of inhaled toxins, and that's more like industrial toxins. But 30-year history of smoking, same idea. So they're just not gonna look good. They're gonna be cyanotic, could have a fever, pale dry mucosa, hypotension, and a fast heart rate, and diminished breath sounds. Another thing that can happen is a pulmonary embolism. We've already talked about that. It's a clot breaks loose and gets trapped in the lungs. And some of our risk factors for those are going to be recent surgery, history of it happening before, obesity, long distance travel, sedentary behavior, and then or really any condition that is going to render that patient immobile and like in the bed. You're going to see fast heart rate, sudden onset of respiratory distress, shoulder, back, chest pain, some cough. If it's a large enough clot, they might just pass out and they will be anxious. Low-grade fever, fatigue, cardiac arrest, yeah, worst case scenario. Okay, so all we're seeing here is that everything is starting to degrade. So, and there you go, and that's part of the reason is our normal vasculature looks like that, but in an unhealthy older population, their vessels might look like that. And that's why we're having a lot more cardiac issues, is because this is what they're working with. The blood vessels also are going to become stiff. So not only do they fill with fat, they can also become stiff. The heart valves don't want to work as well. Okay, so another one is just venous status. It just means that the blood doesn't move around as much, and it can clot actually in the legs. And then if it's worst case scenario, you actually have to amputate the leg because it's been clotted for so long. So silent heart attacks, for example, some women just complain of, for whatever reason, more so older women, they'll have a heart attack and they just complain of upset stomach, kind of nausea, heartburn. That's what it feels like to them. They're actually getting a full-blown heart attack. So you might see some of these things. Okay, there you go. Just more things you might see for any cardiac concerns for the older population. Yep. All right, heart failure. So the risk factors for heart failure is going to be a history of high blood pressure, history of coronary artery disease, and atrial fibrillation, or AFib. And usually at this point in their life, they know they have AFib, and it's monitored with medication, and they see a doctor about it. So remember this thing, we've already talked about this like before, but left-sided heart failure, that fluid's going to back up in the lungs. Right-sided heart failure, the fluid's going to back up in the body, in like the jugular vein. So heart failure, you're going to see all these things. This is pretty similar to like an adult issues with heart issues. Okay, those are some more signs and symptoms we got to keep an eye out for in heart failure. Stroke, we've already talked about this, but we'll review it again. So preventable causes are smoking, obesity, and sedentary lifestyle. High cholesterol and hypertension, some of that is genetic, so there's not much we can do about that. And then, of course, the cardiac disease or AFib, and that's usually all genetic. So signs and symptoms, remember this: slurred speech, visual disturbances, one-sided body weakness, facial paralysis, stuff like that. We remember these. Okay, and just remember, ischemic stroke is when a blood clot blocks the blood flow, and a hemorrhagic stroke is when there's a bleed and it bleeds out. All right, so changes in the nervous system. Basically, this will start to degrade. Like I said, look at that, 5 to 50% loss of neurons. So they are degrading at this point in the nervous system. So the vision starts to go down. Cataracts can develop. Decreased tear production leads to drier eyes. They almost go a little bit colorblind. They have reduced night vision, so that's why older people driving at night can be a little dangerous. Glaucoma, macular degeneration, retinal detachment, those are all eye issues. Hearing goes down as well, especially certain frequencies are harder to hear. And then taste. So they may not eat as much, and that's going to present itself as weight loss, malnutrition, and just generally really tired. Decreased sense of touch and pain reception also goes down, and that's why I mentioned before, where they might actually be in trouble, but they simply just don't feel the pain. Same thing with hot and cold. So even a minor injury, or if the patient says, "Oh, I feel okay," if they're an older person, especially with some pre-existing conditions, we want to really check that injury out. Dementia is a slow onset of progressive disorientation, short attention span, loss of cognitive function. This is a little bit different than Alzheimer's, but they're similar in that the mental ability starts to degrade. And so those are some things that can lead to dementia. They have short-term or long-term memory loss. They may be unable to perform daily routines, appear confused or angry, have impaired judgment, be unable to vocalize pain. So dementia patients, Alzheimer's patients, etc., they can be pretty challenging to treat sometimes. Delirium, this is more like a short-term, sudden thing, like something just happened. And it's a sudden change in mental status and like cognitive ability. So it's usually, like I said, a result of something fixable. So either a tumor, a fever, a metabolic cause, alcohol, drug use, things like that. And look for those things. Look for these red flags in their patient chart. Any sort of psych disorders, as depression, previous malnutrition, or lots of drugs. We call that polypharmacy. So watch out for that. Okay. This is just some possible causes of a older person passing out. Obviously, none of those are good. Okay, neuropathy just means the disorder of the nerve and the peripheral nervous system. So they just don't work as well. And you're going to see muscle weakness, cramps, spasms, loss of balance, loss of coordination, maybe even some numbness and tingling and pain. Okay, so basically reduction in the volume of saliva, dental loss, they might start losing some teeth, changes to gastric motility, just how the intestinal system works, and certain diseases can affect bowel habits and things like diverticulitis, diverticulosis, and then blood flow to the liver declines, which is not good because that liver does a lot for us. Okay, so we already mentioned all these things. Okay, now serious issues that are a problem are GI bleeding, inflammation, infection, and some sort of upper or lower GI tract obstruction. Those are immediate, take to the hospital right now. These are some common ones you might have seen that do need to be looked at, and if they've never been checked out before, they do need to be addressed. But in the short term, if they know they have some sort of lower GI system or a peptic ulcer disease or something, the patients sometimes are a little bit more educated and they know what's happening. Maybe they realize, oh, my stomach's really killing me. Oh, it's because I forgot to take my medication. And those patients are a little bit easier to deal with because they have a history you can work with. So hopefully the patients you're interacting with know what's going on. So for our GI system, what we might see is dark, bloody, like hematemesis just means bloody vomit, or melena, which is bloody stool. It's going to be dark, coffee ground looking. Dyspepsia is just indigestion, enlarged liver, constipation, diarrhea. So there can be quite a spectrum here of GI issues in populations. So all of these are very difficult to assess in the field. An abdominal aortic aneurysm is one of the most rapidly fatal conditions. Anything in the aorta is not good, right? We want that aorta to be solid. So we have to be careful for that condition. Kidneys don't work as well. And remember what we talked about, the kidneys have a huge function in the body of acid-base balance. And once those kidneys start to go down, the body doesn't regulate acid-base balance as well. And that can lead to a whole host of other issues. Okay, incontinence is not a normal part of aging and can lead to urinary tract infections and all sorts of things. So this is actually a pretty big issue, especially for older females. Older women can have a UTI and they can have some pretty serious side effects. They can have altered mental status to the point that they don't even know what's going on. And that looks like it might even mimic a stroke initially because they're so out of it, but in fact, it's just a UTI. Benign prostate hyperplasia. So this is all men. If you live long enough, all men will have an issue with the prostate. And if you look at like the graph of it where the prostate sits, it can actually block off the urethra, blocking it from the bladder. So older men might want to urinate, but the prostate is literally blocking the thing. So you can treat that with some medication. You can even get it removed. There's even some research that lycopene, which is an antioxidant in tomatoes, can help. So there's, at least we're getting a handle on that. There's a few things that can be done to limit the damage. So overall, though, we're going to see slower heart rates, fatigues, drier skin, cold intolerance, weight gain. We're going to see some increase in antidiuretic hormones, so that will cause a fluid imbalance. Increased levels of norepinephrine. Long-term use of norepinephrine is not good for the body. And then you could even have some hyperglycemia or hypoglycemia concerns based on the pancreas. So hyperosmolar hypoglycemic non-ketotic coma is it's kind of similar to DKA or just massive hyperglycemia, but it's going to be a little bit lower. So, but for our purposes, hypoglycemia, hyperglycemia, and just treat those effectively. In the field, whether it's DKA, now if they're in full DKA, sure, that's a different situation. But if they have a blood sugar of 600 or a blood sugar of 1200, either way is hyperglycemic, and we've got to take them. So once again, their body is less able to fight infections. And some people, older populations, the last place they need to be is the hospital, because there's actually a whole host of hospital-acquired illnesses and infections. So hopefully older people can stay out of the hospital as much as possible. We already talked about that. Menopausal women are a little bit higher risk for weaker bone density and breaking bones. And we all make jokes about, oh, I broke a hip, I'm old. But older people do break hips and they die from that. So it actually is a pretty big concern. So yeah, so every part of their body is slowly degrading. That's what we all have to look forward to. Now, the extent of that bone loss and osteoporosis and some of those concerns can be a little bit influenced by diet, alcohol consumption, hormonal factors, and body. So we talked about this. It is a pretty common situation for arthritis, and it just means that the bone ends are kind of rubbing together just from 60 years of wear and tear. So the skin isn't as pliable either. Sometimes it's actually very weak, and tape, if you put tape on skin, if it's that really sticky tape, it'll actually just rip the skin off when you take the tape off. So you need to be a lot more careful. Pretty much in all the procedures and blood pressures and all the things you're taking on an old person, just make sure you do it carefully and you're paying attention because their bodies are different. Pressure ulcers, if you guys are taking CNA, you know all about this. It's basically there's some pressure from the weight of the body and it cuts off blood flow to an area, and the body is just not meant for that to happen. The sore will start to develop. So you don't need to know this on the test. They're not going to ask you the stages of this, but this is just kind of for your information of how it can go down. So stage 1 is minor, it's recoverable. Stage 4 is all the way to the bone, and now they need. So as I mentioned before, the kidneys are not working as well, so that means they're not going to be able to handle certain toxins as well either. So it depends on the older population, but I've seen some older population or some older patients, they might be on 20 different medications, and they can all interact with each other in different times in different ways. So if you have a older patient with lots and lots of medications, definitely slow it down. Be careful. Make sure you're not mixing anything that will cause a bad reaction. So polypharmacy, it just means that there's a ton of drugs on board. Depression is not a normal part of aging, even though it might seem like it is, but it is treatable with medication and some therapy. We just do have to keep an eye out for suicide. So all these things tend to happen when you're older, and it makes you more likely to have depression. And worst case scenario, it could lead to suicide. Generally, older people choose much more lethal methods than younger victims. I think it just because they're smart and they know what they want done, so they make sure they do it right. And once again, these are all things that could happen in the as you get in your last phase of life, and that can affect a person's mentation. So there we go. Okay, mechanisms are a lot more minimal. That's really, how about that? Mechanisms are much more minimal. That just goes across all injuries and illnesses. Just the body does not work as well. It doesn't recuperate as fast. And driving, yes, and you could have some car accidents caused by an elderly driver, and that's because their equilibrium can be messed up, their hearing and vision can go down, all the things. Falls, yep, that is also a thing that happens too. At Primary Health, they do like a fall screen. any person over the age of 65, they talk about, have you ever fallen? What's your house? Are there rugs in your house? Are there handrails on the stairs? They really are, they really care about falls. So, okay, there's a higher mortality rate from penetrating trauma in older adults, especially gunshot wounds. In part, that's just because the body's just not as good, right, as dealing with these changes. So there's more information about falls, and that fall can lead to a fracture if the patient has osteoporosis. And remember, their body doesn't recover as well either. So even for a high ankle sprain, we're not even talking a fracture. Let's just say some high ankle sprain that one of you guys could get. You might be wearing a boot and out of skiing or something for maybe a week or two. Whereas an older person, they might have issues with that ankle for months. So their body does not recover as well. Also, their brain has shrunk inside the skull, right? So that means that brain can literally bounce around inside the head. So even though they might have had a minor fall that wouldn't have done a lot of damage to a 20-year-old, since their brain volume has actually shrank, they can do a lot more damage. Long-term abuse of alcohol is a problem. Really long-term use of any sort of vice, drugs, cigarettes, chewing tobacco, all those things really start to add up at the end. So half of all deaths from hypothermia occur in elderly people. So they're just not good at regulating their temperature. Their body just can't do it as well. Infection control is a big deal here. So you have Staph aureus, which is all over the hospitals, which is methicillin resistant. So, or you even have lower the vancomycin resistant enterococci, which is it's an infection that is pretty much immune to antibiotics. And like vancomycin we call that a big gun. Like that's a big, powerful antibiotic. So if you have some sort of bacteria that is resistant to vancomycin, that's a deal. And these are all just some other issues you might run into there. Most patients are choosing to die at home rather than in a hospital. That makes a lot of sense. That kind of goes into that hospice care thing. And they even have like hospice organizations and kind of take care of all that stuff. Just a reminder on advanced directives, just kind of what's going on. An advanced directive is something that you would have pre-designated on a piece of paper that in case you get incapacitated or something, you could choose what you want, how it's going to go. Now, but you have to be competent when you fill out the form, right? So older than 18, alert, not intoxicated, and is fully aware of the consequences of the decisions they're making, which is slightly different than a do not resuscitate order, which it just means do not start doing CPR and shocking and all that stuff. But do not does not mean do not treat. In fact, some people say, and you can do whatever you want. Some people say, I want CPR, but I don't want to be defibrillated. Or I want CPR and to be defibrillated, but I don't want to get intubated. And that could be in part because they may not really know what that means fully, in that if you're in a CPR situation, you might normally get intubated. But I think they're making the assessment that, well, if I'm getting intubated, I'm in a lot of trouble, and maybe maybe it's not worth it. So they're kind of doing that to save us and save them the havoc of potentially being a vegetable or something like that. So advanced directives, there you go. Some of them are government produced and really fancy. Others are drawn up by a lawyer and they'll be taped on the wall, whatever it may be. Remember, the DNR is only valid if it is written by a physician and everyone's got involved. Unfortunately, a person can't just write something on a piece of paper and turn it in. Like there needs to be lawyers involved. It can be. There needs to be doctors. Really, you have to follow state and local protocols, and it can vary between state to state. Elder abuse is a thing that happens, and that's in that GEMS model. We look at the environmental assessment, we're kind of looking for some of those things. And it's tough, just like child abuse, it's kind of confusing. You don't understand why someone would want to do that, but it does happen. So where we're looking here for red flags, kind of similar to child abuse. Repeated visits to the emergency room, history of being quote unquote accident prone, lots of soft tissue injuries, vague explanation of injuries. That might be a person who doesn't, really can't walk upstairs that well, and doesn't walk upstairs, and then they'll say oh yeah, I fell down the stairs. So well, you really can't go up the stairs. So how did that happen? So certain things like that, like unbelievable, or things just don't check out. That's chronic pain without medical explanation, self-destructive behavior, eating sleep disorders, all that stuff. So this is what we're looking at for the types of abuse that can happen for the elderly population. especially that theft of valuables and embezzlement. Some like grandkids and stuff are real sociopaths, and they will rob their grandparents blind. And looking for signs of physical abuse, this is where we might see some of those. Burns, some of these abusive people like to burn. I don't get it. Cigarette burn, matches, hot water, like immersion into a hot bathtub or something. That's a common you might see. And then that goes back to that kind of that environmental assessment, right? Look in the kitchen, look at what they're wearing, look in the bathroom, like is there toothpaste, is there a new toothbrush, things like that. So overall, guys, it is kind of a depressing chapter because it's getting older is rough, but it's important that EMTs like we're familiar with that population so we can treat them better.